Hi there, my name is Sharon Caravetta and I'm a nurse practitioner. I work with a lot of patients that are trying very hard to lose weight or trying to address issues of insulin resistance. And there's a lot of information that I really want to convey to those patients, but I get such a limited amount of time when you're in clinic that I've decided to put together this video to help just support what we've talked about in clinic and help my patients understand exactly what insulin resistance is. We're also going to talk about prediabetes, diabetes, metabolic syndrome. So sit back and relax and learn a few things about blood glucose and insulin resistance. When talking about disorders of blood glucose, what we're looking at in today's presentation is specifically the ranges and differences in insulin resistance, prediabetes, and diabetes mellitus. Next, we're going to talk about the spectrum of diagnosis. So on this slide, you will see that there are some different ways that we're measuring blood glucose. These are the most common. There are some other things that we do, such as fasting insulin, oral glucose tolerance test, etc. However, the two most common things that you're going to hear are a hemoglobin A1C, also just called an A1C, as well as your fasting plasma glucose levels. So what you're going to hear the most often is talking about the A1C. And the reason why is because an A1C is how well your blood glucose has been managed over the course of 3 months, approximately. So that tells us, hey, this person is doing great on their blood glucose or there's a problem. That's very different than using a fasting plasma glucose. A fasting plasma glucose, all that's going to do is tell us what your blood sugar is at that very moment in time. One number in time is not all that helpful. It is helpful to have a fasting plasma glucose when we're really concerned about daily levels of glucose monitoring for our diabetic patients. And what we'll see is, for example, since an A1C is a 3-month span of time, let's say you have started a new medication or you've started some really substantial dietary and lifestyle changes. Well, those aren't going to be reflected in an A1C for 3 months. So you really can't see how much of a difference that's making. However, if you are taking a fasting glucose, such as with a glucose monitor at home, and you're doing that, weekly, daily, what have you, you're going to see that number trending in a downward direction based upon the interventions that you've taken to move that number. So those are really helpful as well for people who want to be able to monitor their glucose throughout the day. So anyways, those are basically the numbers we're going to talk about today. When you get your lab work, sometimes it's all very confusing because there's so many numbers. When you're looking for your A1C, just make sure you're looking for the word hemoglobin A1C. That's how it's going to be found on your paperwork. And then when you're looking for your fasting plasma glucose, what you're going to look for is the lab value that's called your comprehensive metabolic panel. And the glucose will be the first number there. It's really important that you were fasting in order to consider those numbers valid. So if you were not necessarily being monitored for your glucose at that time and it was not a fasting lab, those numbers being above 100 is not abnormal if you're not fasting. Okay, so what is normal? A hemoglobin A1C that is less than 5.7 is going to be normal. If that A1C is anywhere between 5.7 to 6.4%, that person is pre-diabetic. If that number is greater than 6.5, then that person is diabetic. So that is really significant when we're looking at medications, having insurance approval for medications, etc. That 1/10 of a point makes all the difference. Okay, so here is the process broken down into some pieces with my best effort at creating visuals to help portray the story, to really help you get a grasp of how the process works. So you take a bite of food. That food is going to contain glucose. And here in our picture, the bottom left corner, you see these little blue guys. These will be our representation for glucose. At the moment, they're happy little guys. They go in, they do supply energy to the body. So they're not all bad. Everything's good. And then the bloodstream carries that glucose off throughout the body. The pancreas, that is, remember our second slide, it's right up there in the top left-hand portion of your abdomen. And it's going to be able to sense that you just ate food because it's always on the lookout looking for glucose. As soon as your pancreas sees or senses that there's glucose in the area, there are little cells in your pancreas that will start to secrete insulin. Now, this is the next step here. Insulin, represented by these little yellow guys here on the far right side. Hi, I'm insulin. You can see his little call out there. So the beta cells in the pancreas get triggered. They make these little yellow guys. So just kind of remember, we've got the yellow guys, those are insulin, and we've got our little blue guys, those are glucose. And the glucose was put there by starting the process of eating the cookie. All right, so we're going to start off with what is normal, a healthy glucose transport system, where that A1C, the blood glucose, all in normal range. Okay, so in that scenario, we've got our key players here. You can see on the far left side, we've got the pancreas, we've got the glucose, and we've got the insulin. So right next to our three key players there, you can see that red area. You see those red blood cells flowing through there. That lets you know that is the blood circulation. And then you can see this little barrier, kind of these little yellow balls, the little string of yellow balls, and that is actually going to be representing what is a cell membrane. And the key to getting past that cell membrane is what drives the whole situation of glucose transport. Let me explain. The pancreas sends out insulin, the little yellow key down there. The reason why this is necessary is because without insulin, the glucose shows up and it's not able to get through that little yellow barrier. That little yellow barrier has special cells, special spots that the insulin can attach to. And it turns that, for all intents and purposes, it's like turning a key and opening a little section where glucose can go in. The glucose basically has to bind with that insulin to be able to get into the cells. If it doesn't get into the cells, you can see the liver, fat cells, skeletal muscle, basically all the cells of your body that are requiring energy. That glucose is what feeds them, right? So it comes directly out of your blood, but the glucose cannot get in unless it's got a key, which is insulin. And on this page, you can see that our little insulin guy has actually turned into a key. He's no longer just a little smiley guy. You can see that the key is on there. And there are these little representative areas of where the glucose is able to get through that system. And you can see these little green locks. So this is essentially a very simplified version of it, but this is essentially what has to happen. The pancreas is here. His little call out says, my beta cells can send you all the insulin you need, because he's a happy, healthy little pancreas there. And the glucose says, we need to feed those target cells, but we can't get through. It's like there's a lock on the cell wall. And then the insulin is there. Don't worry, we can be your key. And everybody's happy. The liver's happy, the fat cell's happy, the skeletal muscles are happy, the pancreas is happy, it's doing its job, it's not overworked, all is good. So this is the scenario of what would happen in type 1 diabetes, we're not going to spend a lot of time talking about type 1 diabetes, and that's because type 1 diabetes is a little bit different in that it has absolutely nothing to do with insulin resistance, because in this scenario of type 1 diabetes, there is actually no insulin whatsoever. So it's not an issue that you're becoming resistant to insulin. The problem is you're not making insulin. You can see our pancreas here. He's got this kind of look on his face like, I don't know why you guys are looking at me. I can't make insulin anymore. I can't do it. Sorry. And the glucose, the little blue guys, they're getting very crowded in there. There's way too much glucose building up and they can't get out. There's no way to get through. So in this scenario, they really need the missing key, which is the insulin. But as you can see, the key insulin is basically missing in action. We've got a little missing poster up there for him. He's not anywhere. There is no way for that glucose to get through that cell membrane to the target cells. And in this scenario, then, these people that are suffering from type 1 diabetes, it is absolutely 100% necessary that they have a insulin. It's called insulin dependent because they can't make insulin and their glucose will not go through the cells without it. So that glucose will build up and they will become very, very ill in that situation. That's also called DKA, diabetic ketoacidosis. That is when literally there's the sugar level is so high that you start to have a lot of very serious health complications and you ultimately land in the hospital, and it can be a life-threatening situation. All right, so there's a lot going on in this slide. Let's walk through it together. This slide represents insulin resistance. What you can see here is our pancreas is doing its job, right? It is secreting insulin. Insulin is present in the blood circulation here. You can see some keys mixed in there with the blue guys. However, there's a lot more insulin than there was before. Before we only had 3 little insulin guys because in this little segment, there were 3 locks, right? So with those 3 locks, it gobbled up the 3 insulins and voila, they all got through. But what's going on here? The pancreas is really working hard. It's making more insulin than it did before, a lot more insulin. It's got double what it did in the last one. Instead of just 3, it's got 6 in there, just for this little section. And you can see the keys where that little transport goes through. It looks like only 1 key is working. So let's read a little bit about what's going on here. Our glucose guy is still talking about, hey, we need to get through that cell wall, but there's a lock on it. Insulin's going, yeah, guys, I know, I am a key, but for some reason, some of the locks have become resistant to opening. They're not opening for the insulin. What's happening? Also notice that there's a little bit more fatty tissue here, right? There's more of those yellow blobs that sit on the cell wall. That could be partially what's contributing, right? Because these locks may not work as well when there's a lot more fat there. So as you gain weight, you actually can become more insulin resistant. So in this scenario, insulin is there. The pancreas is more than doing its job. It's producing a lot more insulin than it should have to because only 1 out of 6 in this scenario is working, right? So that leaves, a lot of extra insulin hanging out in the blood. Now, what's important to know is that insulin resistance, the amount of blood sugar, the amount of blue guys here, that could still be completely normal. This person could still have an A1C that's 5.6 or less. And the reason for that is because the pancreas is working so hard. So it's going, oh, that key's not fitting. Now that key's not fitting. I'm going to make more insulin. So it's having to make a whole lot more insulin to be able to get the job done. But it's doing it. But look at that little bead of sweat. This little pancreas is getting very tired. And the target cells, they're getting just enough to survive, They're not super happy because they're not getting it in maybe the timely fashion they would have loved. But at this point, everything is functioning, but that poor pancreas is working awfully hard. And there are a lot of insulin guys having to run around in there with the glucose just to get the job done. All right, so this slide represents what is going on when we have the state of prediabetes. So as you can see, in prediabetes, we've got a lot of keys hanging out, right? So the keys are all there and the glucose, it's getting through, okay? So it's getting through, but unlike insulin resistance, where there were extra keys, but they were managing to keep the number of the little blue guys, the glucose down, they were managing to keep that down in insulin resistance. However, in prediabetes, we are starting to see that there's not enough glucose in the blood to be considered diabetic. The insulin is doing enough of a job so that target cells are getting some glucose. However, they are not doing as good as they could. And why? Because this little guy up here, this poor pancreas, he is working so hard, making so much insulin, putting out those keys to unlock that cell wall for the transport of the glucose into those target cells, but it's just not working. There's just too many of those little areas are little keyholes. You can see they're just not opening for this little guy, and therefore glucose is starting to build up. We're not talking about enough glucose in the blood to be diabetic, but definitely too much and not a normal value. So at this point, the A1C is going to be above 5.6. All right, guys, now we are to type 2 diabetes. Look at this poor pancreas. He is not doing well at all. He has gotten himself all tuckered out. He's got a little thermometer there in his mouth. He's just not feeling well at all. He's really not able to do his job anymore at this point. Look at these glucose. Oh my goodness, what an overcrowding situation we have here. What is this little blue one here on the left side saying? We can't get into those target cells. Maybe we can find some other things to do. Wonder what those other things are going to be. We'll talk about that soon. And then poor insulin. Insulin is just like, okay, guys, I'm really overrun here. I'm trying to do my job. It's just not working. And meanwhile, the target cells are also not happy. They're getting a little bit of what they need, but a lot of those keys, you have to remember, this is just a little diagram to kind of give you an idea. But there are receptor sites where this glucose should be crossing into those target cells all throughout the body, and a bunch of them aren't working. So the keys are unhappy, the pancreas is unhappy, and glucose is a little overcrowded, and we're going to start seeing some problems from that. So this slide just has a quick little side-by-side and understanding those A1C numbers. In the first two here on the left, what you can see is that, in insulin resistance, we've got a few too many keys roaming around, but ultimately the job of keeping these blue guys in check, it's working. The blue guys are not getting overcrowded. There may be an A1C that's maybe a little bit on the higher side, but still within normal ranges, okay? So that's going to be key to understanding the difference between early insulin resistance versus when this has moved beyond that threshold, okay? Next, it's going to be the prediabetes. Prediabetes, remember, your A1C is between 5.7 and 6.4. So there are more little blue guys, little glucose molecules hanging out in the blood than there should be. This is above normal as far as the amount of glucose. However, it is not high enough to be considered diabetic, okay? And then the last one, that one's going to be the diabetes. That is when we have a diabetic A1C, so that's going to be 6.5 or greater, okay? Now, one key thing, just to reiterate, if this was type 1 diabetes, there would be no keys. Remember that, okay? The little yellow guys, the little guys for insulin, those would not be present at all in type 1. That is what makes it very, very different, is that the body, that little pancreas, he's just completely checked out. He's just missing completely in the picture because he's not making any insulin. So these are all pictures of either normal glucose, early insulin resistance, prediabetes, and type 2 diabetes. For those of you that have issues with blood glucose, it's really important that we check your A1C every 3 months. And the reason why is because it does take a full 3 months to really get a full picture of what you're looking at. So let's say you start making substantial dietary and lifestyle changes today. Your A1C will still be reflecting those negative things that you did before you took your changes, and you really won't have a good understanding of how those new changes and what you've been doing or new medications that you've started and that might be helpful. You're not going to be able to really evaluate that for a full 3 months, because remember, an A1C is a 3-month window of time, just looking at what your insulin resistance looks like in the past 3 months. So if you've been really bad for 2 months and really good for the most recent month, it still isn't going to give you the credit for all your good hard work. So keep that in mind. Every 3 months, we want to check these numbers. All right, so remember the caption that we had over our little diabetes, type 2 diabetes slide, where the little blue glucose guy was stating, well, we can't get into the cell. I guess we're going to have to find something else to do, right? So what is that something else that these guys are going to do? Well, it is not going to be anything good. This is a tale of glucose gone bad. Remember, glucose being in normal amounts in your blood, that's perfect. It's healthy. It contributes to a healthy, happy human. However, glucose above that 5.6 radius, and especially above 6.5, 7% radius, then you're going to start to have really, really bad effects, okay? So for your eyes, this is why if you're diabetic and you're coming in for your checks, we want to make sure that you are going to see an eye doctor once a year. You need to stay on top of your vision. It can be completely asymptomatic that something is going on and could potentially risk your vision. And that's just too important of a thing to risk, right? So your eyes rely on very, very tiny little blood vessels, and those are very prone to getting damaged by the havoc that is wreaked when we've got this overcrowding population of glucose. All right, your heart and your brain, again, they need that blood supply. Remember those pictures that you saw? It had, some muscle cells and a liver and even fat cells. They need glucose. When they're not getting it, bad things can happen, right? This is why diabetics are at an increased risk of a heart attack or stroke. Nerves, the blood vessels, when that circulation is so negatively impacted, we start to have a lot of damage to the nerves that, a lot of people who are diabetic, they're probably resonating with this saying, yeah, I get a lot of diabetic nerve pain. And that's something that happens a lot the further you get away from your heart, right? So what's the furthest thing on your body from your heart? That would be your feet. That is why feet, next thing here, the feet are so far away from your heart, they have to rely on a decent circulation to get that blood flow. When you have all that glucose hanging out and you have all the damage that is coming, it's damaging nerves, it's damaging those little nerves in your feet, and it can actually start to really cause a lot of problems. There are issues, diabetic foot ulcers, not uncommon at all in people with uncontrolled diabetes. And unfortunately, if people let this go for too long, a lot of times the nerve damage, that cannot be something that is fixed. The best that we can do is try to get a hold of those glucose numbers and keep it from getting worse. So very important to watch your feet, because your feet are the furthest thing away from your heart. And so if you've got poor circulation, aka uncontrolled diabetes,
that's going to be happening. We're going to have to be checking those feet, making sure that we're doing everything we can to keep the best circulation possible. Your kidneys. Those poor little guys, people have no idea. Those little tiny, tiny blood vessels, and the kidneys are they're true workhorses. They do a ton of work in your body. They are the silent little workhorse there. You don't even really appreciate all that your kidneys are doing until they're not doing it, right? Those little blood vessels in your kidneys, they are very reliant on that good circulation that comes from having healthy blood glucose levels. And this is one of the biggest things. The number one cause of kidney failure in the U.S. is related to blood glucose. So we need to make sure that we're keeping in mind that having too much blood glucose, having your blood glucose too high, it's not just a problem of being too sweet, right? You could be a very sweet person, but we don't want your blood too sweet, because bad things start to happen. And it is not just one area that's going to be affected, it is your entire body. Every single cell in your body is reliant on this glucose transport system from the insulin allowing it in. So if you start having issues with insulin resistance and prediabetes or diabetes, then you are going to start having some signs and symptoms that are very negative and could be potentially very life-altering, especially for those who lose sensation in their feet, start having a lot of nerve pain, suffer strokes, heart attacks, kidney failure, and even potentially lose their vision. So glucose gone bad, it's kind of a cute little slide here. These guys look kind of adorable, but it is actually very sinister and very dangerous.
Now we're going to talk about some of the signs and symptoms of insulin resistance. It is really important to remember that there may be no signs or symptoms of insulin resistance. This is why it's really important that every year you have an annual physical, and that includes having routine blood work, especially blood work that screens for potential issues with insulin resistance. This could include a fasting blood glucose, but even better, an A1C. An A1C should not be drawn more often than every 3 months, because it is a window of how your body has been processing and coping with insulin over the past 3 months. So it doesn't change quickly. It doesn't change overnight. It's not like your fasting blood glucose, which is just point in time of what your glucose was at that moment. An A1C is an average of what your blood glucose has been throughout a 3-month period. Back to some potential changes that we see with insulin resistance. One of the things that you might find is some skin changes. This can be especially noticeable in the armpits and the neck. You might see some darkening of the skin in that area. That's actually called acanthosis nigricans, and it's very common among insulin resistance, prediabetes, and diabetes to start noticing some of these changes. Sometimes the skin also has a little bit more of like a velvety appearance. That's especially more apparent on the neck. Another thing that's very common on the neck can also be on the chest and other areas, but especially the neck, is going to be little tiny skin tags. Those start to develop in response as well very frequently to insulin resistance. Also, abdominal fat, that stubborn fat that just won't come off. If you have a waist circumference of over 35 inches for a woman or over 40 inches for a man, this is considered a risk factor for insulin resistance.
So this is our last slide, and I just want to make sure that we end on a positive note. You do have lots of things that you can do to be proactive about really preventing insulin resistance from worsening into prediabetes or diabetes. There's even research that shows that diabetes, especially when it has been caught early enough, can be put into what we call diabetes in remission, with substantial changes to dietary and lifestyle, and for many with medication management added to the regimen as well. So just keep that in mind. And again, we talked about those risk factors for insulin resistance. So these are basically some of the things that you can do to help reduce those risk factors, all those ones that were in bold, okay? Participating in cardio and strength training exercises every week, making a plan to help you reach your food and exercise goals, ensuring you get high quality sleep and enough of it, eating less processed foods, eating foods that are higher in fiber, move around more during the day. If you have a desk job, make sure you're getting up every now and then and walking, get moving. And then take some steps to actually work on stress reduction. I'll have more videos on that later, but stress is huge. We talked about cortisol and its effects on insulin resistance, lack of sleep, stress, all sorts of bad effects coming from having elevated cortisol levels. And that especially lies in the world of insulin resistance. Thank you guys, and I hope you found the video helpful.